Hi, Mike Schmidt again, Ensemble Ventures. We're here with our Workforce Enablement Seminar Series panel, and this is a unique opportunity to bring these three gentlemen together. They all know each other, but they've never actually sat together in a panel format like this, so this is actually going to be an interesting little process. And what we're going to accomplish here today is kind of review a couple of high-level topics in the healthcare news space, if you will, that might affect Colorado, but more importantly on the healthcare IT side, some of the things going on with the exchanges that are somewhat topical. And I'm really interested in getting the feedback from these gentlemen after they've completed their individual interviews. And like all of our interviews on the program, we'll have the ability to give you access to these sites and the documents and the research that we're talking about. So one of the first things we're going to do today, and I'm going to introduce our panel here. I've got Mark Carlson, who's the Director of Strategic Business at Carrillo, and that's the State Health Information Exchange. Next to him is Mike Ware, who's the CEO of the El Paso County Medical Society, and really got that mandate to look after the independent physicians at the grassroots. And then at his right is Jim Kalani, the CTO for the Colorado Health Partnership, and he's in the weeds solving some of the community health information exchange requirements. So gentlemen, appreciate you coming today and partaking in this interesting experiment we're putting together. So,
thanks, Mike.
Thank you. All right, you bet. All right, so again, we covered a number of topics in our individual interviews, and I wanted to drill down on this HighTech Act, and this was obviously the one that came out initially when the ACA was passed, and it went through the process for EHR and PHR updating, all of the mandates that went down for meaningful care, and what was interesting here is that some of the statistics about what's happened and some of the impacts that have occurred since 2009. Nearly 1/3 of healthcare facilities are choosing a new EHR vendor only 4 years into the Act. So that means 4 years into the Act, 31% of surveyed EHR buyers are ripping and replacing their EHR software. And this is according to Software Advice Research. Of those buyers, dissatisfaction with existing solutions has increased 11%. And I know that, since this result or the act went out in 2009, many survey forecasted healthcare organizations rushed in EHR vendor selections to get the incentives, but they didn't do the homework in terms of the real down and dirty review. So I'm kind of interested to get your perspective, and again, I think most of you here have been involved in the healthcare space within the Colorado community at least 2 years, right? Some a little bit longer. So let's get your perspective on this impact for HighTech and the turbulence in the EHR space and where you see this heading in the future.
Sure, I can start off with some comments. When we started the process of connecting practice EHRs to the data that was present in Carrillo, there were almost 200 EHRs in the marketplace.
This was 5 years ago.
5 years ago. It was the Wild West.
Exactly.
So you certainly had a lot of aggressive activities happening to try and get into the marketplace, get into the physician offices, and sell software that may or may not have met the ultimate needs of what a physician needs to practice. I think as we've moved forward, meaningful use and the requirements to be certified have certainly shaken that tree, and the market is starting to adjust, and the significant larger players that are equipped to be able to manage the needs do still exist. But I think as we will find that usability still is a challenge, and I think it still continues to strain adoption.
Got it. Mike, in your world down at the IPA level, have you seen some disgruntlement and frustration with physicians on this EHR incentive track? Have they been left by the side of the road? I mean, is there some real grumbling at that level?
Yes, there is. And really, there are a couple different reasons for that. One is that the incentives that were offered by the federal government really didn't meet the upfront investment that was required, and that's a lot of the feedback that we get. The other half is that when you're implementing an EHR into your practice, most practices we've seen were trying to make their old paper model fit the EHR, or actually have the EHR fit their old paper model and those workflows, when you really have to redesign your entire workflow processes to make the EHR usable and an effective tool in your practice.
It's interesting, Jim, we talked a little bit about workflow in our interview. Have you seen this impact of a really bad workflow from a number of these EHR vendors? And when you went through your review of some of the new tools that you want to introduce in the market, and I know you're working with Creo and their stack, but you're also opening up the doors to new technologies to deliver. Have you seen the good, bad, and the ugly in terms of EHR workflow?
Certainly. I mean, we've during our project, we've had our share of the same struggles that the physicians face, as well as the same struggles that Creo faces and other HIEs. To that point, I would mention to you, Mike, that one of the things that has been done, and how do you stop this? How do you stop the inconsistency in the disparate systems from working with each other? One of the things that's pretty neat is the ONC recently has some fairly hard-hitting things they may be doing on decertification of EHRs that provide barriers to blocking or make it cost prohibitive for providers to have connectivity with HIEs or other HR systems. So there are some things that are being done on a federal level that hopefully will diminish this disparity of systems.
Interesting. I know we talked a little bit about in some of our interviews about this, the impact of APIs, obviously in application programming interfaces. And again, as stage 3 is now basically in play under the meaningful use, there's a lot of functionalities and interface requirements that are expanding now that you're coming from this top-down state level the exchanges, and we're getting down into the community networks and collaborative care, disease management, and there's a lot more hooks and connection points that needs to happen. Do you see a real need for solid API certification standardization, or is that actually ongoing now, and there are new standards coming to the table to kind of rescue this chaos and mishmash that's happened in the last 5 years? Mark, what's your take?
Yeah, agreed. I think there is an effort to achieve standardization across the industry for advanced exchange capabilities. So a lot of the terminology has been thrown around most recently as FHIR.
FHIR.
That's right. Fast Healthcare Interoperability frameworks.
And that comes out of the HL7 standardization body, FHIR.
That's correct. That's correct. So it looks at ways of mapping ambulatory data in a consistent way so that it's consumable. Because I think that's one of the challenges, cutting back to the previous point with adoption, is that digitizing a practice, it's still a silo.
Absolutely.
And there are specialists that value care notes from the primary care setting, and vice versa.
And how do they get
getting
access
those care
to it?
notes back from the specialist on interpretations and treatment protocols. So being able to expand communication across practices and not just being focused in the acute care setting and getting data from there, I think is going to be a key improvement in area that. And API adoption and frameworks built into applications
will help drive
be
that.
key to that.
Very good. Jim, I know we talked a little bit about your experience with the Colorado Springs Fire Department and their CARES group, the outreach group that reaches the indigent area, people and homeless, and they're out there on the front lines with people. You're experimenting a little bit now with new APIs and tablet interfaces. Maybe you could explore a little bit of that with us today and tell us how that's going.
Certainly. I mean, so for our purposes with CHP, we're having to try and look at different systems and a way to connect those systems into a usable data warehouse. Mark was a little bit humble, so if I can make a small clarification on Creo's accomplishments.
Well, we don't get you guys together that often, so that's why we're going to do that.
I mean, I think it's noteworthy that one of the solutions here, one of the great values of the HIE itself, is to be able to not have 17 different connections between 17 systems,
Absolutely.
but to have one connection into Creo, maybe 17 different ones, and then those systems can work with each other. Back to your point on the CARES program, though. So, for example, we're, as a community partner with the fire department, we're working to actually act kind of as an EHR for the fire department, at least incorporate that data off of tablets, put it into a format that hopefully Mark and team back at Creo say, we can take this and we'll add this in. And so we're actually building our own interfaces,
Would you call that like a grassroots intake platform to get to the EHR model?
Sure, I think so.
And is the FHIR standard playing a role in that, or you're not even at that requirement yet?
Oh no, I mean it will, and a lot of our technology build out is dependent on how fast Korea moves with their technology build out, and so we want to stay pace with them and not get too far ahead of ourselves. So right now it's operating on HL7 version 3 technology.
Gotcha. I know, Mike, in some of our conversations before, you've been investigating and looking at a number of technologies to be able to refer and reference to your independent physicians group, and I know you're still on the hunt, but again, we'll kind of keep that between us girls for now. But there are some real challenges that you've identified as what the base requirements were that needed to be met. Could you share some of those with us?
Yeah, there are a few things that are really key for a number of practices. One is ease of use. It has to be clinically relevant. It has to easily integrate into the practice's workflow. And what we find is a lot of the products on the market really are too advanced for your average 1 to 10 physician practice. So that has to be key. The other is with this particular population of 1 to 10 physician practices, it has to really support the billing and administrative function more than it would in a large health system. And the third piece, finally, is the upfront cost. What we have found is the major barrier is not the monthly fees that a practice would pay for these particular products, but it's the upfront cost. So as much as we can as an organization reduce that upfront cost and really use our pool to pull our resources together to be able to do that, that's going to have some real impact.
Very good, very good. An interesting topical news item, this might be an interesting kind of sideline. I read an article, I think it came out in USA Today, I believe it was last week, or maybe earlier this week, and it was entitled, "Most Doctors Don't Use E-Prescribing for Opioids." So as a lot of people understand, there's a huge opioid abuse epidemic across the country now. And what I found interesting when I read this article in USA Today, that right now only 7% of the doctors are actually using e-prescribing. Now, 3 states mandate it, but the other states it's optional. So if only 7% of the doctors are prescribing or using e-prescribing for opiates, and now we've got a pretty much an epidemic of people who are using handwritten and forged prescriptions to get access to opioid drugs, and they're going to multiple pharmacies to secure these opioid drugs. Isn't this really a situation where you can clamp down on the real requirements for e-prescribing and make this really a mandated requirement for physicians, or is they just don't have the technology or the capabilities or the skills to do this? Why is only 7% of this physician population using this? And I'll start back again with you, Mike.
Okay.
From the IPA or the independent physicians level, what's the barrier? Why don't we have a wide adoption of e-prescribing to meet this challenge?
Well, I mean, that's a good question, and a lot of it comes down to human nature. Is human beings will keep doing what's minimally effective. And so while when you talk to physicians, there's near universal agreement, and my 16 years in this industry have yet to come across a physician that did not think that prescription drug abuse was a problem. The fact of getting them to change the way their practices operate, a way that they may have been functioning for 30 years, is getting that to change is a challenge. And that connects to the broader issue that we all have to deal with as professionals here, and that's health IT adoption. That's using technology to make practices more effective, improve the care that patients get, and all of the things the benefits that come from that. So it really comes back to that, and that's, it's, again, basic human nature is really the reason why I haven't seen widespread adoption.
Mark, plugging in at the state level, are you getting any interfacing with some of the federal organizations about this challenge? Do you have any of these kind of dialogues going on a day-to-day basis, week-to-week basis?
Yeah, well, we're actually likely going to be pursuing a grant that's focused in on increasing visibility on
very good.
basically the PDMP, which is the Prescription Drug Monitoring Program.
Got it.
For the state, being able to link into that and have visibility into all the prescriptions. But from what the article that you referenced, that wouldn't impact it if they're not being sent electronically.
That's right.
I find that interesting, though, because I think e-prescribing is fairly ubiquitous, and it's one of the big gains or one of the few value adds that physicians have identified out of an EHR.
Right.
I think some of that number is inherent with the nature of how drugs are obtained, especially for
Pain
addictive
medication.
behaviors.
Right.
drug seeking going ED to ED, and ERs might not be necessarily e-prescribing out of a.
And they're not capturing that data at the EHR level. And this was part of the argument here was they were not linking the e-prescribing back to the original EHRs, so they're not getting that interdictory information. Hey, if you're going and getting a prescription for this opioid, if you're taking this other medication, you're going to have an interdiction problem, and they're not tying the two worlds together. And this seems to be one element, but the other one is just the sheer number of physicians that are not doing e-prescribing could catch all of these potential flags if it was being done. So if there's only 7% of the physicians doing it, it seems to me that there's got to be some way to interject some type of discipline or strategy at the state level within the HIE stack to say, guys, maybe we can come up with some incentives for you to start using e-prescribing more, right? And here's our tool to make it happen. Is this grant going to be a pilot program to pursue this? Or is it a mandated?
No, I think it's more of a pilot.
Okay.
And, associated with the advanced interoperability initiatives that are happening out of the federal level and the opioid recent fundings, I think, that have been
They're
committed.
jacking them up.
So there's going to be dollars allocated specifically to that. I will note that in the state, there are a number of hospital ERs that are using a tool called Patient Care 360, which is basically our web portal view
very good.
that creates a secure view into the patient's longitudinal record.
And they can see that
So
right off.
if they do have a patient coming in with a nondescript pain saying they just need,
Right.
they can reference this and say, oh, well, this patient was at
Gotcha.
Porter Hospital
Gotcha.
yesterday, same thing. So there is some impacts that we can have, but I think it needs to be
But
more
it's coming.
formalized, and I agree with you in tracking.
It's coming.
I think so.
Okay. Jim, from your perspective down at the community healthcare level and looking at these unique interfaces into these service providers in the market, are you seeing this as a potential barrier that, if e-prescribing is not being done, or you're really not even touching that aspect of it, are you?
Well, certainly. We are. A couple points. The first point is, I know you mentioned that some of this is a fraud with respect to paper scripts, and I don't know that will go away, and it could even get worse with e-prescribing. It just depends. Secondarily, though, I would mention, as long as a prescription, whether it's written on paper or whether it's digitally sent to the pharmacy, if that information is captured within the EHR system, and the EHR system is part of the HIE, then you have actual live clinical or prescription data that you can look at. The other part of that, though, is without those things, then yes, the only way to really track that type of behavior is on claims data, and even prescription claims data, which comes a little more quickly than clinical data, is weeks out. So by the time you might see some type of pattern forming, if it was in fact a prescription paid for by a claim, there could have already been another incident, or that person, a lot of times this population is migratory or transitory too. They may have moved on to another area. So
do you think that happens a lot frequently, that people just move from city to city to
there are people
drug
that
prescriptions?
There are some folks that are known as doc shoppers.
Doc shoppers, okay, great. And from the physician standpoint, Mike, is this a real challenge to get this community to start adopting this more?
That's a good question. It's definitely a challenge it's definitely a challenge addressing the entire prescription drug abuse issue. E-prescribing can help with that. But again, we're talking about a tool. The key with any tool is how it's used, not so much whether the tool's effective, it's how that tool's used.
Right. Okay, good. Listen, if we took a forecast here, and I gave you guys a fairly large venture capital budget, and you can determine what that is. I said forecasting out 3 to 5 years, it seems the healthcare IT landscape is going to look a lot different than it is today. So rapid phase of digital transformation and so forth. So as this technological pace increases, do you believe that these skill sets, talents in the educational institutions are going to catch up with you, okay, or catch up to the needs that you have? And if you were able to make investments in key areas to meet the real challenge you have, what would those areas be? And just give me one or two. So Mark, we'll start off with you. Unlimited budget, but within reason.
And specific to human resources that we could bring on to
Absolutely.
support the tools.
Absolutely.
I
From
think,
the workforce perspective, exactly.
Yeah, I would like, certainly I would target individuals that have depth with technology and data on making sense out of information to make it more meaningful to what our end goal is. But that would have to necessarily be coupled with either healthcare experience or programmatic exposure in a healthcare setting. Almost like a technologist that wants to get into healthcare technology needs to do rounds, just like a physician would.
You mean like an intern or a
Intern at a hospital, do a rotation.
It's an interesting idea.
So that they're getting exposure to the challenges in the day-to-day in healthcare, and specifically physicians and their staff in the challenges confronted on a daily basis in supporting patients. And
Is there
being able to
enough
treat
people that
effectively.
meet that profile right now? Or this is what you're saying, the lack of them is there's just not enough in the pipeline?
We've had some recent success with bringing on some younger.
Millennials
that,
Okay.
but I think the exposure to healthcare is lacking, the
Got it.
understanding and the nimbleness and the ability to pivot within technology is there.
So this is something
They
that our
understand
group,
usability.
the workforce enablement model, as we're trying to share this information with the public, could be a good viable strategy to help kind of bridge these worlds together, because
Yeah.
obviously it's an education of education.
You have
right?
to understand the healthcare challenges on the ground
Yep.
to know that you're not just going to build an app for
Absolutely.
that and say
Yeah.
easy button and it's done, because
Absolutely.
it's not going to work like that.
Exactly. And Jim, you're experimenting with a lot of unique interfaces and so forth. So if you had your venture capital budget and you said, I'm going to invest in these areas, what would those key areas be to make your job easier and address those key challenges you're facing?
I mean, to keep it simple, if I was going to hire a new team of young folks to spend my venture capital money on, I think really the three key components would be mobility, mobile applications, the ability to program mobile devices, and then move forward with the evolving technologies that those mobile devices connect with.
Interesting.
I would say data analytics, certainly.
Got it.
And that's ever evolving. And maybe I would say four.
Okay.
The third one would definitely be cloud computing and the ability to shuck and jive with that arena that's not going to go away. And I think the fourth one, which is probably the sexiest right now, that has been around for a long time, but it's called many different names, but Azure now, machine learning.
Okay.
So artificial intelligence, there's a lot of platforms on that, but actual machine learning, as specifically as it applies to data and population analytics.
Would that, and actually maybe I can expand on that a little bit and draw out from you on your fourth investment thesis, would this actually come in the area of, say, mobile vital sign monitoring and then disease management, where you're bridging those two worlds together?
Certainly.
Okay, so the AI strategy could apply there.
Certainly.
Okay,
Yep.
because it's interesting, because literally 10 years ago, I was part of a team that actually made a proposal to the University of North Carolina. They had a thing called Peers for Progress, which was a diabetes kind of group disease management strategy. And at that time, there was no iPhone, there was no Android. It was basically Windows mobile phones. And we pitched an idea for a vital sign monitoring solution and some little disease management. And it was predominantly in diabetes, where you would have a predictive glucose index monitoring technology. And we were told flat out they loved our solution. I mean, we were out of 100 people, we came in 5th place. They said you did not have a large enough patient population to do the trial. So 10 years ago, we were looking at this strategy, and I think you just kind of buttoned it down with the third piece, or the third leg of the stool. That was mobile technology, vital sign monitoring in the mobile space, the ability to do disease management, and then layering in the AI strategy on top of that. So it's essentially, I don't know if it would be a doctor on a phone, and we wouldn't want to go there because obviously you still want the consultations with a physician, but at least you could be doing some of that day-to-day stuff with that patient.
Well,
Yeah,
if you look,
I was going to say the next gen of this obviously is once the predictive analytics get to that point with that learning, that will be applied to genomic studies.
There you go. You bet.
And eventually, it sounds like science fiction. By the year 2030, there'll be nanobots reconnoitering our body with
Oh my
information about A1C levels and triggering an application either in
And
a cell.
censoring it out of your body.
It's coming in the next 10
Mike,
years.
is that too scary of a world for our physicians base? Are they worried about the future of technology taking over, or what do you think? And again, you still have the venture capital question, so you can still spend your money.
All right.
All right.
It's a good question. So I'll answer the first as far as the physician.
Yeah.
And that is that, like any technological innovation, people will eventually get used to it. They'll integrate that into their workflow. And again, also like most innovations, it'll be, the old way of doing things. As new people come up, they'll adopt the new way of doing things, and it will really, that's how that change will be made. I think we'll find as a culture that we're just as used to that at some point of having just a deep technology helping solve medical problems inside our body as we were at 20 years ago. How scared would people be to know that all of your personal information is carried on a little piece of technology, that you keep in your pocket and you can talk on.
Exactly.
So, as far as the venture capital fund, what I'd say, there are really two key areas that I think need addressed, and that's going to hold back widespread adoption. The first is cybersecurity. I don't believe that we have effectively solved that problem. I think that we're just now realizing, as outside of the IT world of my colleagues here that live in that space, what the dangers are out there and what the needs are. That need for understanding is just spreading out into the general population. The second is the patient side of this. We talk a lot as an industry about the administrative side, the physician side. But if you really want to drive widespread adoption, like any business, get the customers driving the people that they're paying for a service from. In this case, patients pushing medical practices to say, hey, I have this particular patient record. I'm going to go to a practice that also can use this record, and that's going to help me.
Very good.
Yeah.
So you got a very specific area of investment in mind. Okay.
Yeah, you could say that.
Okay.
He's not going to tell you what.
No, exactly. That's holding your
secret
cards
sauce,
close,
man.
Well, gentlemen, listen, I really appreciate the time and joining us for the individual interviews in this panel session. I think we should do it again. I don't know if you're up for a quarterly, or maybe we could do it twice a year, but maybe we won't do it in a studio. We'll do it in a bar or a coffee shop, and we might get some audience participation. But if you're up for that, I'd love to pursue that, because I really do believe that if we can integrate this stack from the state all the way down to the community level through the county, and basically bring a lot of this information to the public so they're up to date on what the real state of the art is, where we're headed, where we're going, and what the needs are. This whole workforce enablement seminar series that we've put together is really designed to bring you closer to this community. And I really think we've hopefully accomplished that today, and I really appreciate your time.
Thank you.
Thanks, Mike. Appreciate it.
Pleasure. All right, that's it for our panel session. There'll be another session after this on the website. And again, on the microsite, you will be able to get additional information and research on all the materials that we covered today. We enjoyed having you with us. Thank you very much.